So next is Airway assessment. It's V4. A 25-year-old driver of a car has been involved in a head-on collision. There was no airbag in the vehicle. He is hypoxic in A&E with obvious bruising to his face and torso. How would you assess him? I would use an ABCD approach. First, assessing his airway by taking care of his spine, maintaining his thoracic spine control, and delivering high flow oxygen. And I will establish the verbal response. If patient responds verbally, then he has no immediate threat to his airway. If there is no response, then my assessment initially will be to look, listen, and feel. So I would do the chin lift and jaw thrust and clear any secretions or blood in his throat. Then I would insert an oropharyngeal airway and assist breathing with self-inflating bag, embu bag, and call for anesthetist to help to secure a definitive airway. I will also look for the use of accessory muscles, any obvious injuries, foreign bodies, evidence of aspiration and cyanosis. Then I will listen for the sounds of upper way blockage like stridor, grunting, gurgling, hoarse voice or breath sound. Then I would feel for any crepitus, equal chest movement and tracheal position. Then I would go toward the circulation with capillary fill, pulse and blood pressure, assess the GCS and check for papillary size, following which I would complete the primary surgery with full exposure. So what are the causes of the airway obstructions? First of all, the soft tissue of the soft palate, including tongue, and then foreign bodies, vomiting, secretion. Third, laryngospasm. Fourth, facial or neck trauma. Number 5, airway edema secondary to the burns and smoke inhalation. So after your initial ABC assessment, his saturation is 86% on high flow oxygen, and there is a bruising and dried blood over his mouth and nose. His pulse is 100 and his respiratory rate is 25. His GCS is 10. What will you do next? So suction the airway, perform jaw thrust while maintaining the cervical spine. If this improves the oxygen, I will insert an oral airway to keep the upper airway patent. This initially improves the things and saturation rises to 92%. The chest X-ray shows bilateral rib fractures, and he clinically has a mid-facial and mandibular fracture. His GCS is 7 now. The anesthetist is busy with another patient. What will you do? So this patient needs a definitive airway, and in view of his facial trauma, a surgical airway would be my first choice. I would perform a surgical cricothyroidotomy, extend the neck looking after the cervical spine. I will locate the thyroid cartilage, and just below it I will feel the cricothyroid membrane and do cricothyroidotomy and put a hemostat to open it, and then we will insert 5 to 7 inch number ETT tube and reapply the surgical collar. Do you know any other types of surgical airways? Yes, a needle cricothyroidotomy converts the emergency to an urgent but does not protect the airway, and there is only minimal exhalation, so carbon dioxide levels accumulate, can only be used for 30 to 40 minutes. Disadvantages are malposition, displacement or kinking of the cannula, and a scalpel bougie technique, faster and easier to perform, higher success rate, low complication rate. And can you describe how you assess a patient for a difficult intubation as mentioned in ATLS manual? So it's a lemon technique: look, evaluate, Mallampati, obstruction and neck mobility. So look for external injuries like beard, protruding incisors and neck. Evaluate the inter-incisor distance, hypomental distance and thyromandibular distance in the finger breadth. And then Mallampati classification, which are 4 grade. Grade 1 you can see all the soft palate and uvula. Grade 2 you can only see the complete uvula. Grade 3 you can only see the base of uvula, and grade 4 you can't see any soft palate at all. So this is called Mallampati classification. And so remember the lemon for ATLS. Thank you.